Everyone,
Yeah.
this is Jingliu.
Okay. This is Dr. Jing Lin. Okay.
For colon cancer screening. The main informations of the patient are as follow. The bowl preparation of this patient seems okay, but still there's some yellow liquid left. We are currently in the sigmoid and about to enter the descending colon. Now we are already at the descending colon. There are lots of twists and turns as you move along the colon. Right now, we are encountering some twists here. We need to withdraw the colonoscope and do some suction. During the examination, try not to inject too much air. That will make the examination more difficult to operate. Sometimes we have to repeat the withdrawal to make the colon straight. If we cannot see the lumen, we must stop going forward. Instead, we need to withdraw the scope and twist slowly, turn left or right to find the lumen. Here's a turn and a little bit difficult to go through. What we need to do in this case is draw back slowly, inject a little bit of air if necessary. We can repeat the withdrawal of the scope, draw back and twist until you see the lumen. Now we are in the descending colon. Moving forward along the colon wall. Encountering some twist here, I am withdrawing the scope and using the suction to make the colon straight. In addition, good bowl preparation is the first step for the colon examination, and it's the most important part to detect any suspect lesions. In this patient, there are still many liquid and sediments left, so the quality of bowl preparation is not very well. We are currently arriving at the transverse colon, now going through the hepatic flexor and about to enter the ascending colon. A little bit twist here. I am using the suction and adjusting the control button. We are going through the ascending colon and finally arriving at the cecum. Enter the end of the terminal ileum. After suction of the water, we can see very nice finger-like villus in there. Without seeing any lesions, I am going back to the cecum. We are now at the cecum. From this moment, we will slowly withdraw and being careful to examine the mucosa in a clockwise fashion to see 330-degree view of the colonic wall. During this part of examination, we need to remove any stool or segment along the way and inspect carefully to look for polyps or any other lesions. To make sure we did not lose any lesions, we always need to go back and forward and do the suction when we finish the inspection at the certain part of the colon. We are moving from the ascending colon backward into the transverse colon to do a 330-degree inspection. When you finish the inspection, we need to use the suction to withdraw the air, and that will make the patient feel more comfortable after the examination, and also is a good way to detect suspect lesions. It is very important to remove any liquid or segment we find along the way that could potentially hide any polyps. Now we are in the transverse colon. Draw back slowly and do the 330-degree inspection. The ball preparation is not good. We need to withdraw and carefully suck the liquid completely, not to lose any lesions under the liquid, using the suction to withdraw the air. Sucking up the liquids. Drawing back slowly and inspect very carefully. Too much liquid here. It takes a lot of time to do the cleaning. "330-degree inspection are very important. Still move backward and forward. Do the inspiration. Clean up the liquid. Make a clockwise inspection. Clockwise moving. Here we are encountering a polyp in the transverse colon. The location is about 40 centimeters to the annulus. After observing the white light view, I transferred to NBI, that is narrowband imaging, to observe the pit pattern. From the color, pit, and vessel, we can make the diagnosis that this is a hyperplastic polyp, which belongs to type 1 by NICE classification. We have to inspect the colon very carefully from this patient. For those patients who are detected with one polyp, they are at high risk to have multiple polyps or even precancerous lesions. Here we can see the mucosa is smooth and the vein is clear. We should pay attention to the broken off veins, which are always signs of neoplastic lesions. From this moment, we need to inspect very carefully to screen either polyps or precancerous lesions. Here is a polyp, also in the transverse colon. It's a flat with smooth surface, not reddish. I'll take the photo under the white light first, and then transfer to NBI to see the color, pitch, and vessels. NBI is narrowband imaging. It is a special imaging technology. It can not only accurately observe the morphology of digestive tract mucosa epithelium, such as epithelial pit structure, but also observe the morphology of epithelial vascular network. Thus, using NBI can improve the accuracy of endoscopic diagnosis. For any suspect lesions, it's better to take a photo from both a distant view and a closer view, inspecting clockwise. Moving back and forward. Inspire the air and occasionally will help you to detect the suspect lesions. We are currently drawing back to the sigmoid. Still, we can spot 3 polyps in the sigmoid. When we take the picture, make sure the lesions are in the middle, and use NBI or other special light to observe the surface structures. I am using the Olympus 290 endoscope, so I use NBI here. For the other endoscopes, like Fuji, we can choose LCI and BLI to observe the color, surface structure, as well as vessel for any suspect lesions. Once we spot any lesion, we have to observe and record the location, the color, the size, and surface structure on it. It is very important to compare the lesion with its surrounding or background mucosas. That will help us to make the right diagnosis. For this polyp, the color and pitch are similar to the background mucosa, and no vessels are observed, so it is a hyperplastic polyp. Since the main purpose of the examination is only for screening, so we will record the exact information for all of the polyps and perform the dissection next time. If possible, we should use NBI and white light very often in order not to lose any lesions. We can see that this patient has many hyperplastic polyps. For the more precise examination, we can use magnification scope to see the magnified view of the suspect lesions, especially for those precancerous lesions. Magnified endoscopy can magnify the mucosal tissue by 1.5 to 150 times. It is helpful to judge the pathological nature of mucosal lesions, to define the infiltration range of lesions, and to improve the accuracy of biopsy by observing the changes of granular duct openings, microvessels, and capillaries on the surface of gastrointestinal mucosa, which has unique advantages in the diagnosis of digestive tract disease, especially in the early stage of tumor. It is also can be combined with pigment staining, electronic staining, high resolution, and other technologies to improve the diagnostic efficiency. Still, in order not to lose any lesions, we repeat to move from the rectum to the sigmoid. Back and forward. More polyps are also detected. From the sigmoid colon, we are now moving back to the rectum. After sucking up the liquids, we spot a plate polyp. On its surface are some sediments. Wash away the sediments and move closer, and then observe with white light and NBI. With similar surface looking to the background, this is also a hyperplastic polyp. We change it into NBI. It has brown color, similar pitch to the surroundings. Then, take a photo for the annals. As the last part of the examination, we will do the retroflexion to look at the anal virgin and look for anything like polyps that could have been missed on the way in or hemorrhoids. This patient has some small hemorrhoids that you can see there. Now, let's suck the air out and finish our examination. Thank you very much. I can't hear anything.
Can't hear me?
I can't hear anything.
Can you?
Oh yeah, it's okay.
好像谁的声音还开着？这个还没变正常。现在声音你要不进谁进来？我没进，我没进。
I'm sorry. I can't hear anything. It's a lot of noise.
Hello.
Yeah.
Did you hear us now?
Professor Mealy, please repeat your question. Okay.
Okay, can proceed to the next video. There's a short try to manage this technical error in communication.
Hello, did you hear us?
I'm Dr. Ge from Zhongnan Hospital, Wuhan University. Today, I will present the case of non-contact magnetic control capsule gastroscope examination from our hospital. At the beginning of 2020, the COVID-19 epidemic outbroke in our city, Wuhan, and now it's spreading all over the world. Although China has effectively controlled the epidemic, there are still risks of occurrence of sporadic and cluster cases. So we have to make the epidemic prevention and control a routine. At this time, the non-contact magnetic control capsule gastroscope shows its special advantages. Compared with the electronic gastroscope, this new way of inspection is much more comfortable and no risk of cross-infection. During the examination, the patient and the doctor are in separated rooms. There is no contact throughout the whole process. Now let's see how to complete it. This is an office lady who is 27 years old. She complained about upper abdominal distension for 1 month. She was healthy before and had no special medical history. The doctor suggested her to have an upper GI examination, and she prefers the magnetic capsule to the normal gastroscope. In the morning of the examination day, the patient should drink a glass of water immediately after getting up, as the battery of the capsule can maintain about 10 hours, so it is totally enough to observe the small intestine if necessary. But if we want to see as more as possible, the intestine preparation is required. 40 minutes before taking the capsule, we told the patient to drink 1 to 10 ml Demisicon to get rid of the bubbles. We also use pronase to eliminate the mucus. 15 minutes after drinking the deformer, the patient can start to drink water, 1 to 200 ml each time, and amount to at least 500 ml to fill up the stomach. Last but most important, remember to remove the metal items such as watches, keys, etc. Now the doctor is checking the equipment, the vest which is used to receive and store signal, and the controlling device. Then she will start to test the capsule. When we make sure the equipment is ready, the doctor comes to the operating room, and then the patient can go into the examination room. The doctor will tell her what to do and how to complete the examination through headset and a microphone. First, wear the vest. Then put the capsule into the mouth, but don't swallow it immediately. Lying down on the left to the bed of the machine, drink a little bit of water and then swallow the capsule. Now we can see the capsule is going through the esophagus. The capsule is now arrived stomach. We can see a lot of water and a little bit of mucus. The doctor is telling the patient to change position to help the movement of the capsule. When the stomach is not expanded enough, we will ask the patient to drink some more water. This is the video taken by the capsule. Now we can see the vision of the esophagus. The mucosa is smooth and the color is pink. Now it comes into the stomach. The position is stomach body. We can see the greater curvature and fundus. Now the doctor is controlling the capsule to approaching the fundus to see the mucosa clearly, and we can see the cardia in this position from the different perspective. We can see the body of stomach. The fold is continuous. We can observe the body completely by turning around the capsule with the movement of magnetic ball. Now we can see the angle and the peristaltic wave from angle to antrum very clearly. These waves can promote the capsule move to the antrum. Now we are approaching the pylorus and trying to go through it again and again. With the movement of it, we can see the mucosa of antrum is smooth and normal. Now the capsule has gone through the pylorus and arrived the duodenal bulb. We can see there is no ulcers, no erosions. After the observing of duodenal bulb, the inspection is over. After the patient has left, we go to the examination room and disinfect the equipment and the room thoroughly. After the examination, the patient can have meals at once. The patient can't take MRI examination until the capsule has excreted out. If the patient is not sure about it after 2 weeks, she should come to the hospital to have an X-ray or a magnetic scan. We use this handle to scan the patient near the abdomen. The light will turn to yellow when the capsule is detected. With the help of the capsule, we have seen the vision of the patient's stomach very clearly, and this is the report which the patient will get. The diagnosis is chronic non-atrophic gastritis, and this is the whole process of the non-contact magnetic control capsule gastroscope. Thank you for your attention, and we are looking forward to see you next time.
We have
Hello.
seen, yeah, I'm Dr. Ali Farag from Cairo, Egypt. We have seen the video of the capsule. It's fantastic resolution.
Thank you.
Your control of the movement of the capsule in the stomach is quite good, but we have some questions about this. First,
Okay.
we have a problem in the duodenum because the passage of the capsule in the duodenum is very fast. Can you control it going in and out or not?
Yes, we can control it, but not for a long time. We can control it with the magnetic balls to pull it out, but pull it out to come out from the pylorus is much more difficult. So we can maintain it for a little bit, maybe 2 minutes, 1 or 2 minutes, but not for a long time.
Okay, my second question is that what's the duration of the study? Because if you have a busy unit, you can't do so many patients. And I know that you have a very busy unit. How much time it takes to perform the examination?
How much what?
Time.
Time.
The duration of the study, the duration of the procedure.
The magnetic control capsule for the stomach, we did it maybe. We have did it for 30 cases.
No, it takes 30 minutes, 15 minutes, or only 10 minutes for the study.
10分钟之内结束吗？还多久结束？
多久结？ No, half an hour.
Half an hour. This is
half an hour.
Really a big time. If you add to it the preparation, it will be almost 1 hour.
This is a new equipment for even for our department, and we are we want to find out the way the whole process, and we even try to pull out the capsule to see much more about the esophagus with a little string, on it. So the time we did the esophagus maybe much more. Even though we have done the 30 cases, I think maybe we will go to the even efficient process the next time.
I understand that you don't have the ability to have a biopsy. So how do you choose your patient? Of course, you choose patients who doesn't do the biopsy. How can you choose your patient for the study?
Maybe first of all, the very elderly person who can't take the normal examination of the endoscopy, and this examination even in our country, it's very expensive, so we can't have much more choices. But the bleeding, upper GI bleeding, or older person patient is the choose one. And the patient who is taken aspirin for normal, they can't get through the normal gastroscope, and is suitable for the capsule, magnetic capsule.
What is the type of this magnetic capsule? Is it or Olympus?
Anhan company of
China.
Anhan company of China. We have two products from Jinshan company and Anhan company. Anhan company is usually used in the upper GI examination, and the Jinshan company is
seen it.
used for the small intestine.
Mhm.
Can you extend your exam for the small bowel also, or just for stomach upper? Can you
Really?
do the same?
As I said in the video, the battery can maintain about 10 hours, so it is totally enough to observe the small intestine. But we usually communicate with the patient or evaluate the patients even suitable for observe the small intestine. And if we want to see it, if we want to see as much as possible, we should ask the patients to do the intestine preparation, drink some DEG and a lot of water to make the intestine very clean.
Yes, it is maybe interesting for the small bowels to win time if you do your capsule, this magnetic capsule. It's interesting. Maybe you can win time for the small bowel.
The battery is can maintain about 10 hours.
10 hours,
So
yes.
so I think it's enough.
Okay.
Jean-Francois, we are using the Oncon system in my unit since nearly 2 years. And compared to the previous first clinical trial with Olympus 10 years ago, the magnetic from Oncon is easy to handle. It's very small unit. And what we are doing by the time in non-sensitive patients, we use the Oncon capsule for stomach, and we will start next year a trial in France to see how we could use capsule instead of gastroscopy. And by the time being, we use also in my unit with a prep. This morning I did a capsule for gastric. And then we pass the capsule in the small bowel, and the patient will be a full small bowel examination. It's a very, very interesting device. You have to understand in China, there are a lot of early gastric cancer. And so that capsule, this capsule, Oncon capsule, it's very, very important for them. I think there are 200 units in China using this equipment. And is not so well known outside China, but I think he had a rich future.
Okay, we move now to the next video. Dr. Jun Lin, please.
Patient, 45-year-old female. Chief complaint, physical examination. And 6 cycles of chemotherapy currently. With upper GI endoscope, a submucosal lesion with smooth surface and moderate mobility is seen on the posterior wall of gastric fundus. EUS shows the gastric wall has clear layers, and the lesion, which is originated from muscularis propria, shows hypoechoic changes and uniform echo. The lesion is about 0.9 centimeter by 1 centimeter. Diagnosis: submucosal lesion of gastric fundus. Procedure: endoscopic submucosal excavation. Performer: Professor Junlin.
A
submucosal lesion with smooth surface and moderate mobility is seen on the posterior wall of gastric fundus. After the lesion is identified under direct view of the endoscope, the superficial mucosa of the lesion is marked with APC to determine the location of the tumor. Several milliliters of mixed solution containing glycerol-fructose and methylene blue solution is injected into the submucosal layer with an injection needle, and the non-drifting sign is positive. Two-thirds circumferential mucosal and submucosal layer incision is performed around the marked dots with a dual knife. Small vessels of cutting surface are coagulated directly by the knife. A gray-white lesion is seen in the muscularis propria. The lesion is continued to be dissected by the dual knife until exposure of the root of the tumor is achieved. Small vessels of cutting surface are coagulated directly by the knife. Small vessels of cutting surface are coagulated directly by the knife. At the base of resulting artificial ulcer, the hemostatic forceps are used to stop the bleeding and to prevent delayed bleeding. Now, the root of the tumor is fully exposed. Subsequently, several milliliters of solution is injected between the submucosal layer and the tumor. The separation of submucosal layer and the tumor is performed carefully with a dual knife. Small vessels of cutting surface are coagulated by the knife. The hemostatic forceps are used to stop the bleeding. lesion is completely removed. With a semi-free artery-based mucosal flap left. The tumor dimensions are about 1 cm by 1 cm by 1.2 centimeters. After resection of the lesion, there is no residual lesion or perforation at the base of resulting artificial ulcer. Finally, the incision is closed with a semi-free flap by multiple titanium clamps. The specimen is collected and sent to pathology department. With incision is covered by an artery-based flap. ESE has shorter wound closure time. Besides, it is easy to suture in case of perforation, which reduces the rate of infection. Thanks for watching.